Well, good morning, Stephanie. Thank you for being here with me today. I am excited, as usual, to talk about this conversation because, as we've talked about in the past, that this is a very, very popular, I'll say, issue in the gastroparesis community, talking about SIBO, and I know we'll dive a little bit deeper into that and what that means for the gastroparesis patients. But before we do, I'll give you some time to introduce yourself to our audience.
Yeah, absolutely. So my name's Stephanie Mendez. I am a registered dietitian and board certified specialist in digestive health. So I'm essentially a certified GI dietitian. My journey started because I had my own chronic GI issues for a very long time. I used to work in the music industry, but just became really passionate on finding a way to feel better for myself and then wanting to help others. So I decided to change careers and become a GI dietitian. So I became a dietitian 4 years ago. It hasn't been that long, but I have learned so much. I started my internship at Cleveland Clinic, where I got a ton of GI experience in their IBD center, Center for Gut Rehab and Transplant, colorectal surgery. In my first few jobs, I was an IBD dietitian. I did some more general GI health, and then now I work as the GI dietitian at the Cedars-Sinai GI Motility Center. So I see both adult and pediatric patients with a lot of complex gastrointestinal motility disorders. We are a second opinion center, meaning they have seen at least one other GI provider before they come to see us. So we get a lot of the complex cases. But I can see patients with gastroparesis, SIBO, IBS, and then anything that affects the motility. So that can be chronic intestinal pseudoobstruction, people who have a lot of surgical history that causes adhesions, small bowel obstructions, Parkinson's disease, literally anything that starts to affect how someone can move their bowels is what we see. And that's where I am now.
Well, for a short period of time, you have sure done a lot.
Yes, I have. I've had at least 3 lives, I say.
That's amazing, though. And, for our community in particular, even if you don't 100% specialize in gastroparesis, with all of that experience that you have, just makes treating us complex cases, even better for us because you've had all of that outside experience. So that's wonderful. And thank you for sharing that.
Sure.
So today's topic is SIBO and gastroparesis because we cannot stop talking about it, because as much as I think we get a straight answer from some physicians, not everybody does, or they're just not sure what to do. And one of the biggest things that we as a community have found are the contraindications around the diet, because what works for someone who is dealing with SIBO but doesn't have maybe slow motility or has different tolerances with gastroparesis, what's recommended one usually doesn't work for the other, and vice versa. So we get a little bit stuck. So definitely wanted to break it down a little bit more today and see if we can help some more people out. So in a more scientific way than I just explained, do you have a way to share why it's so complicated for one versus the other? Maybe what feeds the intestinal bacteria overgrowth and why that particular food works so well for gastroparesis but not SIBO. I asked that for personally, so this is really just for me, but
Yeah, absolutely. So with both of these conditions, there is usually an underlying motility problem, right? It's usually a slowing down of the GI intestine. So with gastroparesis, it's mostly affecting the stomach, and then with SIBO, it can affect the small intestine and the large intestine. So when you have things that are just slowly moving, that can cause a lot of symptoms. And with generally speaking, with diet, a lot of times the recommendations do contradict themselves when it comes to gastroparesis and SIBO. The most obvious one is with gastroparesis, it's recommended to do small frequent meals throughout the day, and then SIBO to space your meals out at 4 to 5 hours apart. That's the first question I get is how do I do that if I have both? And essentially, I will say a lot of what information people find online or maybe get a handout by their provider is very generalized. And there are ways that you can individualize it. I've seen everything across the spectrum from what patients can tolerate. And I think sometimes patients just want to feel better, so they want to follow everything correctly. But there are times where they can tolerate something that maybe is not necessarily recommended for someone with gastroparesis or SIBO. So I like to help people figure that out. But that's essentially, they're different parts of the body, and so with the gastroparesis, we want to not delay stomach emptying any further. further. So we want things that are easy to digest, that will move quickly. And a lot of times patients are getting very full very quickly. They can't hold a lot of food. And then the lower part of the intestine, still they can do better with like things that are easy to digest. But a lot of times we're trying to give the lower intestines a break. So that's why we do recommend spacing meals a little bit more apart. But happy to dive into this more as we go on today. I know we will, to kind of help clarify that a little bit.
Yeah, I learned more in just a couple minutes from you than I did my physician the first time. They were like, you have SIBO. And I'm like, what's that? What do I do? So thank you for that.
Sure.
I know, like, personally, I have recurrent bouts of SIBO, and I have since the first time I was officially diagnosed. You take the medication, you know, you feel better, but it just seems to, at least for me and some other people in our community that I see, it just keeps coming back. So having a diagnosis of gastroparesis and then developing SIBO, is that something that you see often?
I will say it's definitely common because the both of them are like, because when there's a issue with motility, right, that's what can cause someone to have gastroparesis. And then because of that, the motility is usually not just in one part of the body. It's not just in the stomach, it affects everything. So then that can make SIBO very common to reoccur. So I will say it's super common. I would say actually in my personal experience and practice, patients may have an overlapping of SIBO, but I'm often finding that when I'm meeting with patients, we're just focusing on one. Like if they have gastroparesis, that's really prominent. We're just really trying to make sure they can get enough food and not be malnourished. And then if their gastroparesis has been around for years and they're like, I know how to control this, my SIBO is a little bit more prominent, we're kind of just focusing on SIBO. So there's probably an overlap that I'm seeing, you know, that there is there more often, but in my memory, I'm not remembering it so closely like that. It's usually like one is the big thing we're focusing on. But I know with the providers I work with, it's definitely common. So I don't want to say that my personal experience is that it's not, it is.
Yeah, I know. With my symptoms, and one of the things I think are starting to pop up is because there's a lot of symptom overlap. So when something is bothersome, if you're feeling really bloated or that intolerance is happening, if you've never been officially diagnosed with SIBO or you don't know what it is, you don't realize that maybe that's part of your symptoms, and maybe, you know, what you're doing with your diet might be unintentionally making something worse because there is such overlap. So it's very interesting to see when people are like, you know, I'm feeling this extra bloating, I really feel terrible. When I start to feel a lot bigger or my stomach feels a lot tighter than normal, I'm like, this is above average bloating for me, or this is above average like nausea and intolerance. So what am I dealing with now? Is this just an extra flare, or is this SIBO? So as we talk more about it in the community, you know, we don't want to over-test, but you want to make sure that you're treated properly. So it's one of those things that providing the information, the education is really important so people do get tested. Because if it sits there for longer, it's not helping anybody. It's just making your symptoms feel that much worse.
Yeah, absolutely.
Now, one of the things I did want to ask you about was about like low FODMAP diets and low fermentation diets, because as a general rule, and you probably know this because we complain about it all the time, that we are just given a low FODMAP diet or a suggestion of that from our, you know, dietitian, from our GI doctor, like right in the beginning. So that might not always work. Because it's too much of an elimination, or you might, like you said earlier, tolerate something on the list, but it's on the no list, so you want to follow it. But that's different from the low fermentation, and, you know, our community might not have heard much about that, if you don't mind explaining a little bit more.
Yeah, absolutely. So the low fermentation diet was developed by Dr. Mark Pimentel at Cedars-Sinai, and this was actually created a while ago, and so it was created before the low FODMAP diet even came out. And from my understanding from working with them, is what they've told me is they had so many patients coming to them asking what can they eat when they had SIBO. And so they were just trying to get ahead of it and like, how can I create some information for patients so that they're not going crazy with trying to figure out every little detail of like a food they can eat. We wanted them to like go out and have a life and be able to eat at restaurants. And so that's where they created this. So the idea is that the foods on there are lower fermenting. When you compare it to low FODMAP, there can be some contradicting things in there when you break it down by food group. But essentially, if you don't compare it, because it was created before that knowledge came out, and you overall look at the entire diet, it is, if someone followed it, it is lower fermenting. And so it emphasizes like spacing meals 4 to 5 hours apart. That's one of the really big principles, because that is supposed to help the migrating motor complex, which is this big like clean sweeping wave that comes and helps to push food along. And so spacing meals apart can allow that to happen maybe once or twice in between meals. So that is a big principle of it. And then it's emphasis on the fermentability of food. So there's like a few big things that it recommends not to consume, which are like pre and probiotics, especially in containing foods, artificial sweeteners, sugar, alcohols, cruciferous vegetables, legumes, lactose. And then there are a lot of other things on there, but that's where I do start to work with patients. I don't want them to, because you can also be overwhelmed on this diet. I don't want them to be overwhelmed either.
Yeah.
So I always try to pull patients back and have them think of the big picture. But that's the general sense. I have a lot of patients that find it easier to follow. It's less restrictive than the low FODMAP diet, and it can be followed for a longer period of time than the low FODMAP diet. But I don't recommend for patients to follow it forever, maybe just to manage symptoms when they're really prevalent. And then I like to help them to try to come off of it after a while.
Yeah, I think the biggest thing that around diet for gastroparesis is just not knowing what to do. And all of these contraindications, you're looking at it as a patient who has no real nutritional background. You might understand some things, but the heavy duty nutritional background is just not there. So you're looking at all these things, you're like, what the heck do I eat? And it just feels like you don't want to try something because you don't want to make something worse, but you need to eat something. So it's very difficult to try to manage that without someone like yourself or another dietitian to really help individualize that approach for you. And I would imagine that everybody is different, but you do see some similarities across the board of what might work for this population of patients, like the low fermentation diet. So how important is symptom prioritization when creating a nutrition plan?
It is extremely important. I will definitely say that. So the example that I like to give is, for example, with some patients who have gastroparesis, when it is so severe that they are just having a hard time keeping any food down and they are losing weight, they are having nausea every day, vomiting after meals, that becomes the priority. Even if they had SIBO on top of that, I wouldn't even worry about the SIBO at that point. My priority for that patient would be to not have them get to malnutrition. So I want to prevent malnutrition. And then I want to make sure that they're able to meet their basic nutrition needs. So can they get the minimum calories that they need? Can they get the minimum nutrients that they need so they don't develop any deficiencies? Sometimes this might mean focusing on like liquid nutrition only or shakes. And sometimes some of these patients have to go on tube feeds. And so in that example, that's obviously a more severe case of gastroparesis, but that's where my focus is mainly going to help this patient just be able to keep food down. And then, for example, if I have another patient who has either mild to moderate gastroparesis or they've just had it for a very long time that they know how to manage it, and then they get this onset of bloating pretty quickly after meals, both in the lower upper abdomen. They're constipated. They're having a lot of abdominal distension and pain. And that's when I would start to focus more on the SIBO picture, right? So in my clinic, I know if a patient has SIBO or not. I'm not just assuming. Just say that patient has SIBO, then we can start to work on, okay, your gastroparesis is pretty well controlled. Your primary symptoms are now this bloating that is making it hard for you to find things to eat. Then we can start looking at lower fermenting foods, seeing in their diet what they're eating. Is there anything we can kind of adjust? And I find if we only focus on the priorities, that can help not make things so overwhelming, right? We're not trying to tackle 10 things at once. We're trying to tackle the primary symptom that's preventing them from eating adequately.
Yeah, now that approach sounds incredibly refreshing because trial and error around this disease sucks. So, trying to really look at that and say, let's just focus here, we'll try this. If that doesn't work, then kind of moving on. And that's where even just like elimination diets, when you eliminate everything and then maybe you feel better, but you don't know what the heck made you feel better of what you eliminated. So it's like when we try to do trial and error on our own, because again, you just want to feel better. So you kind of are like pushed in the direction mentally to just stop doing everything because you don't want to. And then it gets harder to try new things as you're going along too, with that trial and error, to say, okay, I want to pull something back in. So the way that you just described that approach feels safe. Around trial and error, how do you approach that in a way that feels more structured rather than really overwhelming when it comes to dealing with, I'm like, let me ask that all over again. So how do you approach trial and error in a way that feels structured rather than overwhelming for patients?
This is a great question because it's something I often encounter with patients, right? Most patients are not coming to, like I touched on earlier, a dietitian right away. They're coming after years of trying things on their own first and not really getting anywhere, which can be so, I did the same thing. It can be so like challenging and heartbreaking because you're like, this diet stuff makes sense. Like I could do this myself, right? Like that's how at least I felt. But first I just always assess, like, is diet the trigger? And when I work with patients and I kind of get a food journal from them and I can kind of see their symptoms, I can tell a little bit if there is a really big dietary trigger or if something else is going on. Even just from patients like answering my question. So if I have a patient that's like, oh, it's like garlic and onion, or it's specific foods, or, I only get bloated after dinner, then, we can kind of really start to go down and see, like, well, what are they eating? On the other hand, I have patients that are like, I am bloated no matter what. If I don't eat, if I eat, if I wake up bloated, I am bloated by the end of the day. Sure, food can still have an impact, but there's probably something else going on that is just making them constantly bloated. And one of the big things I often find is constipation. So what I tell patients, I was like, because they usually want to try something. I'm like, let's manage your constipation first. Let's focus on that. Because if you have a lot of bloating, we really need to get the bowels moved to kind of see how much bloating is left after you're not constipated. So they'll work with our providers, usually get started on some sort of medication or do like a bowel clean out. And then with me, after that, I'll say, like, do we need to start a fiber supplement? Do we need to get them just to eat breakfast first if they're skipping breakfast? Kind of work on some just dietary behaviors before we even start going down the rabbit hole of like what foods are triggering symptoms. If all of that is kind of ruled out or has already happened, then that's when I think trial and error can be very helpful of like seeing what works and what doesn't. And I like to usually do this with just a few foods. So I've hardly ever done a full low FODMAP diet on patients. I've only, I think, had 3 patients that really wanted to do it. So worked with them through that, hardly ever use a low FODMAP diet. I really look at what they're eating, what is most likely triggering their symptoms. Maybe if they're like, I think it might be garlic and onion and maybe dairy, then I'm like, all right, why don't we can take those 2 foods out for a week or 2, bring them back in, or just do one at a time. So I kind of try to individualize it, bring it down to just a few foods that they're adding back. And that way they know a little bit more or less what is working or what is not as a food intolerance. The other thing too is when patients have so many symptoms, it might not be the time to trial and error diet. So if their gastroparesis is severe, if they are just severely bloated, they're having severe abdominal pain, like they don't even know what their baseline is, then I usually won't do any food challenges. Because unless I get them to like a mild or moderate phase, I want them to know, if you ate this food and your symptoms got worse, would you notice? And I have some patients that are like, I wouldn't notice right now. My symptoms are so severe, they're happening every day. I don't think I would notice if they're like, I don't even know if it's possible if they get worse. So I think that kind of like working on all of those things can be really helpful and make diet feel less overwhelming when we finally get to that point when it makes sense to do a food challenge.
Yeah, no, that's great. I'm like, every time, like, I wish someone had done that with me. I love that approach because it does feel like it gives control back, even if it doesn't necessarily give control back. As a patient, when you're doing that, it feels less just pick and choose, like just try this or try that, and looking at it holistically rather than just looking at a diet trigger, because anybody knows, and you bringing up constipation, I'm like, I swear everything always comes back to poop.
I know.
It always comes back to poop. But it's so true. There's not one person in our community that will like go against that, because we're all chronically constipated, whether it's because we're just not drinking enough, or we have slow motility in the bowels as well, or we're not eating enough, so you're not able to move enough through your body to have consistent bowel movements, or you're not absorbing your medication. I'm like, we're all chronically constipated and we're just always full. Like, it's how it happens. And sometimes that's not your first line to think that is affecting everything, you know, in the upper GI as well. And I never thought of that until I started paying attention to my symptoms. So I'm glad you do the same.
And it's such a good point. I'm glad you brought that up, because I did want to touch on that too, is especially with the overlap of SIBO and gastroparesis, the more predominant symptom for both of those is when it's on top of gastroparesis. Obviously SIBO can have diarrhea, but is constipation when those two overlap. I only have like 5% of patients with gastroparesis that are more diarrhea predominant, which is very interesting. But most are constipated. And so for both SIBO and gastroparesis, I really do check on that, because I've had a patient with gastroparesis that, it wasn't with Cedars, it was with another job, so I wasn't working with the provider. And I was like, oh, when was the last time you had a bowel movement? And she was like, 2 weeks ago. I was like, we really need to troubleshoot that and focus on that before we do anything else. So I had her start like a motility agent, like a over-the-counter supplement, and then she started going, and then she was able to tolerate more foods. Same with SIBO. Again, patients want to go down the do's and don'ts of like a low fermentation diet, and like, oh, well, there's this product and it has this on the last ingredient, and I usually say, okay, yeah, we can talk about that, but I try to, you know, provide education, but I'm like, but you're only having a bowel movement 2 to 3 times a week. So that is actually more of your priority right now, because that has a higher chance of the SIBO not going away or the SIBO returning if your bowels aren't moving versus that ingredient in that product. So then I'll have them like shift their focus to say, okay, let's focus on foods for constipation. Let's focus on, you know, getting things moving. Like you said, make sure they're hydrating. Are they, there's some non-diet therapies as well that patients can do, like abdominal massage, going on a walk, some exercise to help get things moving. So yeah, constipation is so important. And I want patients to just remember that, like, that if anything else, if you have constipation, just focus on that.
Yeah. Yes, I'm like, I'm never not focused on it at this point in my life.
Same.
But tracking sometimes can be overwhelming in itself. So how, you know, with that approach, what else might you want to track with your patients coming in besides symptoms? Do you have them track like bowel movements, you know, anything super specific around their macros with what they're eating? Or is it really just symptom management that you want to see to start anyway?
Yeah, I would say first, I always ask patients if tracking would trigger any more like food vigilance, right? Like there's already some patients who have been tracking. I have patients that come to me and have been tracking for 2 years and they're exhausted. And I'm like, you know, so it's always helpful. I will say it's always so helpful as a dietitian to have more data, but I will try to do without it if I can, if it's going to make the patient just, you know, have more disordered eating thoughts or anything like that. So I'll first assess if a food journal is appropriate. And then the other big thing is oftentimes, even after I explain it, patients will just send back their food only. And I always like to tell them, I'm not just like the food police. I'm not just judging what you're eating just to judge it. I really try to make sure, I'm like, can you put your food, can you put the timing and the timing of your symptoms? So I like to call it a food symptom journal, because the relation of the timing to the food is what's going to be most important. Do your symptoms occur 20 minutes after? Do your symptoms occur 3 to 4 hours after? Do symptoms occur the next day? That tells us a little bit more about the foods and potentially what foods can be triggering. Meal size can be helpful, and any like more specific information about the food and like how much, I would say, fluid intake. A lot of patients don't know how much they're drinking, which can help too. But that's the really big key, is that timestamp and the symptoms. So sometimes I do have patients repeat it if they're okay with it, or else I really won't know like how to help them if I'm trying to help manage their GI symptoms and all I have is what they eat. I don't really know how to correlate the two.
Yeah, I know, like laughing a little bit, I'm like, I'm so tired of tracking, you know, and I've had to take tracking breaks for myself because I don't really track calories. I just track like what the meal is and the symptoms around the meal, exactly like what you're saying, and kind of putting that into a note on my phone, or I use an app now just so that way I can see the timing. How many bowel movements did I have? What type of bowel movement did I have? And because of those timestamps, I can see, how long after meals, around meals, did something trigger a migraine? Did something trigger nausea, vomiting, and a migraine? Did the migraine trigger, it's like, it is very overwhelming at times, because I know I love data. I love to see it myself. It's very interesting to me, but it can feel so overwhelming that, like, if that's all you're looking at, if that's all you're digging into every single day, it's like the data starts to drive your symptoms rather than your symptoms driving the data. So I've definitely taken those steps back. And just as a patient, I appreciate that you, as the professional and the expert in the space, is also acknowledging that sometimes that's not the way to go. But I think instinctively we think, in order to get the information, I have to track everything. You need to know everything. I need to give you all this information. But sometimes it's not necessary. But there are those core components that really are. So that's just really appreciated.
Yeah, and the other thing I will note on that is I have patients that, like I said, will say, oh, I've been tracking for 2 years. I can't figure out anything that's a food trigger, which might definitely be true. But this is where I highly recommend doing this with a GI dietitian. This is my first plug for my field, because I really think we can be helpful. Is sometimes, like, we are trained to look at all those random patterns that may not be obvious to a patient. So if they've been doing it forever, they're not seeing anything, there is a chance that they're just like, if they're too close to it, that they need like a second eye, a pair of eyes to look at it. So that's when I'd really encourage them to work with a dietitian, so they can look at their food symptom journal as well, and help them see if there's any food triggers. Because sometimes, like, for example, I had one patient with gastroparesis that it wasn't actually anything she was eating. She was doing great on like particle size modification and texture modification, but I think her meals were just a little bit too large. She was still eating 3 meals a day and things like that. So there can be a whole different other way of eating behaviors that can impact symptoms, not necessarily the specific foods that I think could be helpful for patients to know.
Yeah, I noticed that myself, actually, where my largest meal of the day would usually be breakfast, because, you're like unintentionally fasting all night, right? So my stomach was as empty as it was ever going to be in the morning. So I did my best in the morning, but slowly but surely, like, that size meal just wasn't working anymore. And I kept trying, because I'm like, I always eat this for breakfast. It's fine. It wasn't the food. It was how much of the food I was trying to eat. And then once I pulled a little bit out, I could still eat those same foods, but at a smaller amount. And then I just tried to add some other calories in other places throughout the day, so I wasn't losing the calories, but I just couldn't eat that same meal anymore. And you're like, yes, talk to a dietitian. I'm like, yes, I probably should have brought that up to somebody. Since I see a couple dietitians, I'm like, I probably should have brought that up to somebody. But it is really helpful to just have that second set of eyes. And I tell everybody all the time, they're like, I don't know what to eat. I'm like, go see a GI dietitian. Would you like a list? I'm like, please go talk to somebody, because
we're not the first thing that comes to mind. Even when I was a patient, I went to functional medicine. I didn't even think of a dietitian. So we have some marketing to do for ourselves, for sure.
Well, we do our best over here, because it really is. I'm like, no one even suggested it to me. Like, I heard the word GI dietitian, I think it was maybe almost 2 years ago now. I was diagnosed in 2014.
Wow.
I'm like, what? And you guys have been here the whole time. It just was like, it's not, like you said, that necessarily the first thought, but just we're so glad you guys are here now. So one of the things I definitely wanted to touch on around SIBO was mBIOTA, because I have used it myself, and I know some people in the community have, and it's a great option for those who can tolerate it, talk with their GI dietitian and their medical team about if an elemental diet can be helpful. And since I'm a little bit biased, but it's one of the best out there, so I wanted you to share a little bit about how that could work for somebody who's dealing with SIBO, and basically what the heck an elemental diet is.
Absolutely. Again, I did not know about an elemental diet before it became a dietitian, so this is not something most people should know. And specifically, I'm going to talk about mBIOTA. mBIOTA it's a specialized liquid elemental nutrition formula. So it's designed to be taken for 2 to 4 weeks and to replace all solid food for the duration. And it is considered a medical food, so it should be done under medical supervision. This isn't something I recommend just to do on a whim or to try it on your own. There's like a whole process that your provider would probably want to do. For example, like testing for SIBO, making sure you even have SIBO in the first place before
important.
You do the mBIOTA. But the elemental piece, so traditional shakes that are not elemental diet, they contain intact proteins, other ingredients that require more digestion. With an elemental diet, it means that the nutrition components are broken down into their basic components. So proteins are broken down into amino acids, carbohydrates are in the form of simple sugars, and then fats are in the form of medium chain triglycerides, or MCTs. And then there's also added essential vitamins, minerals, and electrolytes to it. So the reason why this can be really helpful for someone with SIBO, and it has been studied specifically in mBIOTA has specifically been studied in patients with SIBO, and then elemental diets in general have been studied in EOE, eosinophilic esophagitis, and Crohn's disease. But they can be helpful for patients with SIBO because everything's already broken down. It gets absorbed very quickly in the upper small intestine. So your body doesn't have to do the work. It's getting absorbed in the higher gut. And that allows your lower intestines to kind of quote unquote rest. So the bacteria that can't feed off of anything, they will die off, and that can reduce the gas levels. If someone has elevated hydrogen or methane or hydrogen sulfide, that's where it can help patients with SIBO.
That's so interesting. Like, to think about that. Again, I look back at this and I'm like, you could have done that. You could have offered that to me. All these years ago. It's definitely, I love these conversations, but they are also personally frustrating when I think back to all the things that we could have learned all those years ago after they give you this diagnosis and you say, now what? They're like, bye. I'm like, thank you. Very helpful. So with, like you mentioned, with an elemental diet. So if somebody suspects SIBO, or maybe they have this, they got the diagnosis and they're in that position of now what? How would somebody how would you recommend somebody bringing this up to their physician, like that they want to try it and talk to the medical team, and then they would order it themselves? Or is that something that maybe the medical team, someone like yourself, could help them kind of figure out the timing, how to take it, etc.? Because as you noted, you don't really want to do that completely on your own.
Yeah, absolutely. So if they have been diagnosed with SIBO, I think that's already a good starting point for their provider. That means their provider believes in SIBO and that they have diagnosed them with SIBO, and they are most likely familiar with all obviously the treatment methods, not obviously the antibiotics, but then elemental diet. So I will say, usually, patients end up doing a round or two or more of antibiotics. And then when elemental diet makes sense is if SIBO continues to recur after the antibiotic treatment, or if the antibiotic isn't doing anything for their SIBO. So it's not meant to be done alongside an antibiotic course or another treatment. It's meant to be a standalone treatment. But they can bring it up to their provider. Like, so if they're in that case where their SIBO keeps recurring or they're not responding to the antibiotics, they can ask their provider if their provider is familiar with elemental diet and if they can do this course. Most providers, I think, would be familiar with elemental diet. They may not all know about mBIOTA yet. But they can bring this up to them. There is even a study that we can link if they want to bring that study to their providers. And they can just let them know it's a more palatable form. So a lot of the research on elemental diet in adults in the past had high dropout rates because of how poor it tasted, that patients couldn't even go through the entire research duration. But now with mBIOTA, it's way more palatable. We even had 100% retention rate in all of the participants in the study that Cedars-Sinai did. So that is like the thing that's checked off now. Now you know you can, it's something that's tastes well to drink, but they can bring it to their provider and say, hey, here's the data, can I try this? And then see what their provider says.
Now, because gastroparesis tends to not be the only issue, and there are some like co-conditions around that, are there any of those co-conditions that mBIOTA might be contraindicated in use for?
Yes, absolutely. So remember, this is a 2-week course of a full liquid diet. So this is not for everyone, whether or not they had another condition, and I will list some of these conditions. But for some patients, a full liquid diet for 2 weeks is just not feasible. But specifically in patients that have a low BMI, that are malnourished, that have a history of eating disorders or disordered eating, or diabetes. Diabetes or prediabetes or a history of unstable blood sugars, we would recommend that they consult with their physician first before starting this. And especially with diabetes, that they should be managed with their endocrinologist or their diabetes dietitian to help manage their blood sugars while they're taking elemental diet. Now, with that said, specifically, the 2-week course is not indicated for someone with malnutrition or low BMI, but using elemental as supplemental nutrition can be helpful for patients who need to gain weight or who need extra nutrients, who may not be able to tolerate other nutrition shakes, for example. So sometimes we will have patients use this pack on top of what they're eating orally to get an extra 300 calories a day.
Okay. That's really helpful to know, because there are, you see something and it looks really good, and maybe it is, but that doesn't necessarily mean that it's good for your current situation, depending on, where you fall in that. So that's really helpful. Yeah. So after the 2-week course of the elemental diet, what is someone to expect after finishing that? They've gone through, they followed it, they did 100%. Yeah. What are the next steps, or what could they expect?
So for some patients, I will say, like during the course first, in the beginning, they may have like some altered bowel movement. So if they were previously constipated, they may have more loose stool in the beginning. We suspect that's due maybe to the MCT oil, because MCT oil is a type of thing that needs to be adjusted when you take it. You shouldn't take like a large dose all at once. So sometimes when you're starting it out, your body's not used to having that only, and there can be like some looser stools, things like that. And then I would say a few days in, patients do start to adjust. Some patients will see an impact like within the first week, but for some patients, they may not see an impact on their symptoms closer to the end of the course. So usually if patients are constipated, have diarrhea, or have bloating, they will see an improvement in those symptoms with doing the 2-week course. Now, I will say that's not the case for everyone. We do have some patients, a handful of patients, where the elemental diet didn't help with their symptoms. But for the majority of patients, it will help while they're on the course. The hard part is it doesn't always last, and I know we can go into that more, but sometimes when patients go back to a regular diet, their symptoms can't come back, but they do feel better while they're on elemental. And then if they do a repeat breath test afterwards, not all providers do this, but sometimes if they were elevated in hydrogen, that level may go down, methane, et cetera, then the gas levels may go down.
Mm-hmm. So reintroducing food, would that be a good time to start a version or a variation of like the low fermentation diet? So that way you're not just going from, an all liquid diet right back into where you normally were, because you might not tolerate that. Even if you tolerated it before, after going on just a liquid diet, like elemental diet aside, but all liquid diet for 2 weeks and then going back into food, I can't imagine that's going to be really comfortable. So is there, and that would fall into trial and error as well, but like, what does that transition look like, especially for somebody with gastroparesis?
Yeah, so what I would recommend usually for the first 2 days after they complete the course, the 2-week course, is I usually recommend to do a really bland diet. So this is like chicken, fish, white rice, pasta, sourdough bread, and eggs. And that's usually what we recommend for 1 to 2 days to give the body time to adjust. If they have extra packets of the mBIOTA elemental, they can always keep taking 1 or 2 and slowly transition back to regular food. And then after those 2 days, at our clinic, we do recommend that they go on low fermentation for at least a month, anywhere from 2 weeks to a month. And just like you said, just to ease that transition back to some of these higher fermenting foods. And what we really kind of have patients, the main food group to really watch when you're reintroducing is the fiber. So they can really slowly bring back fiber. Obviously, we wouldn't recommend that they go from those 2 days to like, I'm going to go have a salad. We usually maybe it's just like 1 fruit or 1 vegetable for that day. They're chewing it really well. They're cooking it or putting it in a smoothie so it's well blended. Like they're trying to find a way to get it pre-digested, like in a sense, like the shake is. The elemental diet is broken down even further, but at least they can pre-digest the food to help their gut not have to do so much work all of a sudden, but slowly get back to learning how to digest food again.
I'm a person with gastroparesis that like I need at least like maybe a couple bites of toast, a little bit of a cracker to be able to tolerate that amount of liquid. And, you know, if you are slowly digesting, that amount of liquid can feel really heavy in your stomach. Is there a way for gastroparesis patients in particular to kind of increase their tolerability of all of that liquid that they might not be used to if they're not on an all liquid diet already? Mm-hmm. Or the amount of liquid.
Yeah, they can ease into it and ease out of it. So they can start replacing like one meal a day the week before if they wanted to just start to get like used to that sensation. Like you're saying, if they're not used to an all liquid diet, again, the packs are going to come for 2 weeks only, but sometimes some patients don't need all 6 based on their body size and appetite and everything. So there could be a sense where there's extra packs, or they buy extra packs and they replace one meal a day and maybe like kind of slowly increase that as they're getting close to the full 2-week course. And then they can sip it slowly throughout the day. So they can sip the shakes a little slowly. They don't have to drink the whole thing in like 5 minutes. They can go as long as 40 minutes to slowly sip it. And then they can see how they're feeling, right? Like, so this isn't something that no matter how they feel, they have to complete the course. If they're just feeling really terrible, they're not able to tolerate the liquid for that long, like this may not be the diet for them.
Yeah. Yeah, but it sounds like it could be some part of their diet, maybe not, like you said, the whole full 2 weeks, but maybe just having a shake or two during the day, they could essentially still see some benefit from doing that, whether it's just calories and tolerating that shake over other protein or nutritional shakes for people, or maybe that could help with some of their symptoms. So there definitely could be a benefit of just having 1 or 2 shakes a day, where I think sometimes you can feel like a failure, you know, especially with gastroparesis and all of that trial and error and all of these things that you're trying to do and they don't work, right? That you can feel a little bit like a failure. So it's nice to know that the option is that you can have just 1 or 2 shakes. You can add it to your diet if it's tolerable for you and still see some benefit from it when you can't tolerate everything, because we never know what we're going to tolerate. And you don't know, you could tolerate it on Monday and not tolerate it on Tuesday and then start tolerating it again on Friday. We never know what's going to happen.
Yeah, because symptoms can always shift and change, and that's the hard and challenging part of any chronic GI condition, I would say.
Yeah, I think for us in particular, I mean, I can only speak on our GI disease, but I think that collectively we just see that over and over again, that the only thing that's predictable about this disease is the unpredictability. And when you add these other issues on top of it, whether you're looking at just chronic constipation and then you're looking at SIBO, like I know for myself with the recurrent SIBO, I'm on a 2-week on, 2-week off antibiotic regimen right now to see if we can kind of kick it, because it just was constantly coming back and that continued to slow the motility. So I had downstream issues, upstream issues, like everything stream issues. And I'm like, now what do I eat? You know, and I look at this, I'm like, I don't know what to eat anymore, because what worked yesterday is not working today. This meal isn't just too big, it's now too small. I'm not getting the calories, I don't tolerate the shake, and it can be just so overwhelmingly frustrating when you have all of these issues. They're all happening at the same time, and you're trying to figure it out basically on your own, because your doctors, you know, as wonderful as they might be, they're not here to figure out the nutrition piece of it for you, and they're not there to help you figure out what works and what doesn't. They can a little bit, but that's where having the conversation around nutrition with the dietitian is so incredibly important, because just based on my own experience, I'm like, I wish I had this years ago. I might have figured some things out sooner. It might not have changed the course of direction for me. It might not have changed like my outcomes, but I feel like it would have made it feel more supportive, and I would have learned a lot more and maybe had a couple more better days in between, and maybe tried some new foods or found some ways around life that I wouldn't have had prior to that. So it's just really good to know that there are more people out there that actually know what they're doing.
Yes. And the really amazing thing as a GI dietitian is we work with hundreds or thousands of patients, and we get to see patterns, like kind of like, because you're in an organization where you talk to so many people with gastroparesis. Sounds like you're also seeing like, here's this things like a lot of people say or experience. We get to get that subjective information as well, and are able to help, because we're like, oh, I've seen this 20 other times, and some of these things may have worked. Not to say everything works for every person, but we at least have some tools in our toolbox that we can help you when something arises, right?
Yeah, that's really important, especially now that we see more people with other co-conditions that like we as a patient community, we knew that all these things were related. We just needed the experts and the science to kind of catch up to us. But you have things like mast cell activation syndrome now that can cause a lot of GI issues and a lot of GI upset. You're having these reactions to these foods or medications that you're like, now what do I eat? Again, this is where you need to work with somebody to help figure that out with you and really say, this is a good thing to try, and you feel safe trying it. I can't tell you how many things I've tried over the years that I'm like, I kind of cross my fingers and hope this works.
Yeah.
And it's just really hard. And we see that with so many people. You mentioned earlier about like probiotics around the low fermentation diet. And a lot of that is marketed toward our condition or similar conditions. Like, take a probiotic, it'll fix you. Take a probiotic, you'll feel better. Maybe somebody does, maybe somebody doesn't. But they need to get that information from somebody else to say, is this good for me, or could this unintentionally cause harm? Especially if you're on a low fermentation diet, you don't realize that your probiotic might be making that worse.
Yeah. Yeah, and it's so hard when you guys get marketed this just not accurate or not evidence-based information, and I know so many patients just want to feel better, so they're going to try anything, right? Yeah. But yeah, with probiotics, we are just not there in the data to know that what needs to be adjusted in your microbiome, that this probiotic is the right key for that, the piece that's missing. Yeah. And so myself, and I know almost any of the providers and people that I work with, I went to a talk with the founder of the Gut Microbiome Project, and he also does not recommend probiotics. I just don't think it's there yet to where we want it to be to work.
Yeah, but you definitely hit the nail on the head that we will almost always try anything to feel better, because we have felt so terrible for so long that sometimes you see something and you want that thing to make you feel better. And especially with SIBO, like I was, the first time I was diagnosed, I think was probably around like maybe 2015 or 2016. So it was a long time ago. And I don't remember if my provider brought it up or I was Googling my symptoms and asked a question like, how do I get tested for this? But I'm just knowing what I know now and seeing what patients are going through now, I'm incredibly grateful to that physician that they took it seriously enough to actually get tested, right? Because like you had said earlier, if they believe in SIBO, believe it's a thing, if you're having all of these symptoms, you're like, I don't know what to do for myself. I can't figure this out. What do I do? Could it be this? And they blow you off, but maybe it actually is SIBO. Maybe there are things that you could do to help your symptoms. So I think about that and I'm like, well, I'm glad somebody listened. I don't know. I don't remember which physician it was. I remember sitting in the room and drinking that terrible sugary water and breathing into the bags and the tubes and everything, and sitting there miserable for hours going through the test. But it got me an answer, and that was incredibly helpful. I didn't fix my diet around anything, but it's really good now, I think, to know to ask those questions and trying to figure out, what do I do? And as much as I wish that you had a solid answer of like, this is why this diet works and this why this one isn't, I think truly the answer is to work with someone to help you figure out what works with you. And that's an answer that might be frustrating because it's not just a one-size-fits-all approach or a diet or a medication or anything, but that I think is going to be the best way to find what works for everybody, what works for you, whether or not mBIOTA is going to work for you. You know, hopefully something like that does. If your body is dealing with this recurrently, and really can get you to a better, healthier place, because we just want everybody eating as much as they can with the least amount of symptoms possible.
Yeah, and I love that you reiterated working with someone. So I highly recommend it, because from the provider perspective, one, you want to find out if you have SIBO, and then two, you want to find out why. So SIBO is usually a secondary condition to something else, right? So if people are just going online trying to treat SIBO themselves and not finding out why they have SIBO, that can just constantly not help and not make the symptoms continue to come back or be present. And providers have a whole toolbox of medications and motility agents that they use that can help keep things moving so that the SIBO doesn't reoccur. So I always recommend working with providers if possible. And then when it comes to diet, I do want to make sure that I state that there is no diet out there, whether it's low fermentation, low FODMAPs, there's SIBO diet, SIBO biphasic diet, all of these, they have not been actually studied in SIBO patients. So we don't know that if someone follows it, that this is going to guarantee that they don't get SIBO to return, or that their SIBO goes away. So I always like to state that, to try to just help patients not feel so overwhelmed. Because I have patients that follow low fermentation diet to a T and SIBO comes back, and then I have patients that follow it and then SIBO doesn't come back. So it's not guaranteed. So that makes me feel more comfortable as a provider to say well, let's figure out what works for you and what doesn't work for you, instead of following any of these diets that are on paper, because they may or may not work. And that can help patients be oh, great, I didn't have to worry about monk fruit and that fifth ingredient in the product that they were, eating. So I try to just because I was a patient too, so I know what that feels like, and I just want people to not have to be hypervigilant around food all the time.
Yeah, it's exhausting. It's exhausting reading every food label, thinking that this is my life forever. And, maybe you do have to do some version of that a little bit every single day, because our digestive issues, unfortunately, there is no cure for gastroparesis. So we are going to have to be vigilant to a degree, but maybe not that hypervigilance that comes with feeling out of control. And around the food and that unpredictability we talked about earlier, I think it's so easy to fall into hypervigilance and looking at everything and trying every new diet and constantly looking for information, where maybe if we step back a little bit, and I say this from my own personal experience, that it wasn't until I kind of zoomed out and said, this is not helping me. I need somebody who understands this, that can help me work through this to get me where I need to be. And it wasn't until I was able to do that with a provider that I started to see a marginal difference in how I was tolerating things. And then if something came back, if SIBO flared back up, or if gastroparesis was flaring, my food tolerance changed, I didn't get so scared right away. And that to me was the biggest piece that I could have taken away from that, was I felt more in control of my actions, of what I could do. And I learned from that provider to say, okay, panicking, that feeling is not going to help me here. You have some tools, and you have somebody on speed dial to say, I tried these things. I went back to all of the things you taught me and it didn't work. Now what can I do? Can we reevaluate what I'm doing now? Let's look at this and see if you can help me identify a pattern that I'm not seeing. And it wasn't until I did that I started to notice a difference. And that was a big deal for me. And I think probably anybody would feel similarly, because we feel so out of control way too often with this disease in itself.
Yeah, absolutely.
But well, thank you so much for this chat today. I have learned so much. I always do from our dietitians. I know that our community will very much benefit from all the information that you shared today, because it's just questions constantly. So if the one thing we can reiterate is go see a GI dietitian, I'm like, if that's
Yeah.
all you take from this, that's still okay. And we will definitely, share any other information on mBIOTA if anyone is interested, and any of the clinical studies as well.
Yeah, and if anyone is looking for a GI dietitian, I'm sure there's a resource or link that we can find as well. I'm able to see patients in California virtually, and our clinic doesn't take insurance, but I think my rate is like $170 an hour.
Okay.
So it's still, I know it's not affordable for everyone, but it's still cheaper than some private practice dietitian. So if anyone's looking for me, maybe we can link to the motility center if someone
Absolutely.
wants to work with me as well. And then, there are so many GI dietitians out in other states if people are living in other states and want to work with someone as well.
Yeah. Well, thank you so much.
Of course. Thank you for having me. I didn't even know I was constipated till I became a GI dietitian. And then I was like, oh, I've had chronic constipation my entire life. And that's why I've always struggled with poops, and I was bloated and everything. And now that I'm actually managing my constipation, my bloating is significantly